Good afternoon and welcome to the NorthShore Outcomes Research Seminar and the 9th in our COVID-19 research series. Today, Dr. Catalin Buhimshi will be joining us to present his research on COVID-19 infection and vertical transmission in an underserved Chicago patient population. Dr. Buhimshi comes from the University of Illinois, Chicago. We will also be joined by an expert panel, including Dr. Melissa Simon from Northwestern, Dr. Annie Dude from the University of Chicago, and Dr. Beth Plunkett from the NorthShore University HealthSystem. Next. I'd like to start off by thanking all first responders and those working on the front lines during this pandemic. Send a special thank you to Dr. Bernard Ibigman, the Director of Outcomes Research Network, to the NorthShore leadership and to the program directors in the Outcomes Research Network and staff for the ongoing support to make this seminar possible. My name is Sean David. I am a program director for translational science in the Outcomes Research Network at NorthShore and a clinical professor of family medicine at the University of Chicago Pritzker School of Medicine. And Rachel Brewington is the facilitator for this webinar, and she is going to be co-hosting with me today. Just to start off, thank you all for joining us. We're excited about today's seminar and our expert panel and speaker. NorthShore Outcomes Research Network was structured with key academic leadership and provides support to catalyze research across our institution, as well as through collaborations with the Institute for Translational Medicine, our CTSA, and the broader Chicagoland research communities. The goals of our Outcomes Research Network are to enable uniform community access to care that is effective, efficient, and equitable, to enrich the practice of medicine, and to support strategic clinical quality and operational decision-making. So we're really focusing on research that is really useful to the community as well as to our health system and the care of our patients. The overall objectives for this seminar series are to really promote the flourishing of principal investigators, to disseminate our research activities and resources to the broader research community, and to promote a culture of collaboration and team science. We want to bridge people together to their peer communities, be silo-free, and really create a team science culture that will continue to lead on to other things. And ultimately to deliver outcomes research that demonstrates improved patient population health outcomes and health equity for our communities. So I'd like to, if we can move on to the next slide. And Rachel.
Okay, thank you so much, Dr. David, and hello, everyone. In today's webinar, all attendees will be muted with the exception of our panelists and speakers. However, there will be some opportunity for interaction. If you have any questions or comments at any point during the presentation or the Incubator Hub discussion, please submit your communication by using the chat function as noted by the blue arrow on the screen. If you are on a computer, you can access this icon by hovering your mouse over the bottom of your Zoom screen. Please give special attention to the audience of your message before you submit it. As you can see on the image to the right, you can choose the message either the panelists and speakers. This will include myself, or you can choose to message everyone on the webinar. Feel free to leave your questions and comments at any point during the presentation. If you are experiencing any technical difficulties, please let me know by messaging all panelists and I will assist you as best I can. Okay, I'm going to hand it back over to Dr. David, who will go over our agenda for the day.
Thank you very much, Rachel. So this is an overview of the agenda for the seminar today. We'll start off after the introduction of Dr. Buhimshi with the lecture where he will present on his work in COVID-19 infection and vertical transmission in an underserved Chicago patient population. That will be a 30 minutes presentation. And during that presentation, we encourage you to submit any comments or questions using the comment function. And we will collect those and be able to deliver those to Dr. Buhimshi. Also think of comments and questions for the expert panel. We'll be taking those comments as well in our Incubation Hub expert panel session. So we'll have 10 minutes to cover questions and answers. And then we'll have the Incubator Hub expert panel discussion, where we're going to be reintroducing the expert panel members, Dr. Simon, Dr. Plunkett, and Dr. Duty. And we'll have an opportunity to go over the implications of this work, first for health equity, as well as for clinical implementation, dissemination, for policy, and for future translational research directions. And then we'll follow up with some closing remarks where we have an opportunity for you to submit your evaluations of the seminar. And we'll send a link to the video upload on our YouTube channel, which will be available probably this evening or tomorrow morning. And so this can be archived for any of your faculty, any of your students who would like to miss this and would like to be able to watch it. So that's the overall agenda for today. So I'd like to start off, and it's my honor to introduce Dr. Cataline Buhimshi, who is a professor of obstetrics and gynecology, also director of the Division of Maternal Fetal Medicine and director of Obstetrics Service and Patient Safety. And he is a director of Maternal Fetal Medicine Fellowship, as well as program Department of Obstetrics and Gynecology at the University of Illinois College of Medicine in Chicago. Dr. Buhimshi has a long career of scholarship in health disparities and obstetrical issues in maternal fetal medicine. And we are really delighted that he is here today to present his work and the work of the UIC group throughout Chicagoland on this important topic. So without any further ado, I would like to introduce Dr. Buhimshi to start off the presentation.
Thank you, Dr. David, and I just want to begin by thanking you for inviting me, Rachel, and it's truly a great honor for me to be, part of the same panel with Dr. Plunkett, with Dr. Dude, and with Dr. Simon. And I was in particularly touched by Dr. Simon, who told me that she's going to connect and participate today on her birthday. So I'm just wishing her happy birthday from all of us. With that saying, my intention today is to have a general presentation and to discuss a little bit about the challenges on healthcare during this pandemic period, but also to share with you some of the experiences that we had at the University of Illinois Chicago during the last 14 to 15 months. Next slide, please. I think at this point, it is very well known to all of us that in December 2019, when COVID pandemic came up for the first time, it was a condition and a disease that we did not know what we were going to face. At the center of this pandemic was Dr. Shi Zhengli. Next slide, please. She has a history of long tradition in studying coronavirus, the harboring of coronavirus by bats. And among many scientific careers as a recognition for her work, she was elected the director of her institute in Wuhan, China. Next, please. In 2005, Dr. Zhengli published one of the first papers that made us aware of the fact that the bats are in fact natural reservoirs for SARS-like coronavirus. Next, please. And that work was followed also by this very important work that was published in Nature Medicine. She published this paper and this article with a group of scientists from North Carolina University. Next, please. And the relevance and the importance is that they created, in fact, a chimeric viral construct that mimic the spike protein of the coronavirus, and using very sophisticated genetic modeling, they were able to predict, in fact, if this coronavirus has the capability of intercross species. It was very obvious that this virus, in fact, had the capability of passing to humans. And as you can see on the right side of the slide, they demonstrated that this passage and this cross passage, it can happen via a secondary host or eventually through a direct human infection. And I think this was very, very innovative work at that time, and in fact predicted what is going to happen to the world a few years later. Next, please. Very well known, the World Health Organization reported officially on December 31st, 2019, the existence of pneumonia of unknown causes, and this was in China. Next. This announcement was followed by recognition of the virus in the United States in January 19, 2020. Next, please. And also in January 24, 2019, by the recognition of the coronavirus in France, Europe. Next, please. This unknown pneumonia was obviously traced in China. Next, please. But very interesting, there was a lot of controversy related to the time and how much time, in fact, the virus was present in the human community even before we recognize the disease itself. The work that I am presenting right now and I'm referring to, it's a very smart work from a group of students from Harvard University. Next, please. That demonstrated in August through February 2020 that the trafficking of patients at the Wuhan hospital, main principal hospital in the same region that it was considered the epicenter of the pandemic, was hugely increased beginning actually with September. On the left side, you're going to see the highlighted dots that they are cars. And obviously the satellite images demonstrated a slowly decreasing traffic toward February 2020. The hypothesis was that in August, September 2019, already the virus was part of the community with many patients presented to the hospital for treatment. Next, please. Obviously, the controversy continued because in the United States, it was perceived that the virus was much earlier present than its first recognition in California. Next. Which in fact created and put a lot of pressure on at least the healthcare system in the United States. So the main question is, what was the coronavirus crisis reveals about the American medicine in general? Next, please. I think we all agree that during the pandemic, it was revealed that the United States health system has a lot of strength, and probably one of the most relevant is the frank heroism and ingenuity of the healthcare providers at the very beginning, but also it demonstrated weaknesses that we are very well aware of by this time. Next, please. I think we have seen that probably many, not very too many countries in the world have been able to mobilize at the level that we have been able to mobilize, with bringing even hospitals in New York, but also demonstrated, next please, the unlimited human creativity through identifying so many ways to protect themselves. Next, please. that involved not only the use of plastic bottles, but also involvement of the Formula One racing cars that design devices to maintain open the upper respiratory system of the patients. Next, please. With finally the evidence that a group of 4 students in Afghanistan have been able to develop a ventilator using old car parts, which I thought that it was extremely ingenious, but also so inspiring. Next, please. So what we have seen in terms of, challenges, I think what we have seen, and we had a lot of challenges at the very beginning related to personal protective, the availability of personal protective equipment, the existence of the supportive devices, but also the challenges that we encounter to have our N95 masks. Next, please. There are several reasons for this, and some of them, they have to do with the rules of microeconomics and macroeconomics in the United States. One of them is the fact that the United States company, in fact, function based on group purchasing organization with the choosing the cheapest bid for production of various products, which suggests that a lot of these products were actually manufactured outside the United States. Next, please. And also, lastly, many of the companies are trying to avoid the cost of storing or storage and the inventory related to storage of various protective equipment. In the United States in particular, that will add significantly to the cost of next, please. So what we have also seen that the strategic national stockpile and the storage of the equipment cannot fulfill everyone's needs. I think by this time we are very much aware of the challenges that we had in having FEMA providing the equipment that was necessary for so many parts in so many cities in the United States. Next, please. Obviously, the detection kit was a very big challenge in order to identify and isolate the patients. And this was an continuous battle for many, many months that actually led the Federal Drug Administration FDA to use and to approve the emergency use authorization for manufacturing the various detection kits and equipment that was necessary. Next, please. But what we have seen that that most they like access to primary care. Next. It is obvious that in the United States, there's approximately ICU beds capacity of 45,000 ICU beds, and to deal with severe respiratory illnesses, the inventory and the bed capacity, it should be at least to 2.9 million beds that were needed at the peak of the pandemic. Next. Which will demand very difficult to meet. The other thing is that the way that the healthcare system is functioning in the United States, the CMS and the Medicaid services are not paying for a standby capacity. So in other words, we are not paid and reimbursed for maintenance of a group of beds that they are available in time, such as a pandemic. Ultimately, that led to a challenge because hospitals, they do not have extra beds available for emergency situations. Next. John Adams is considered the founder of the healthcare system in the United States. Next. His major contribution was that he actually, under his administration, the first federal public health law was published. and it's consistent with every seaman at the American ports to pay 20 cents per month in order to have the ability to be examined physically and receive medical care. That's in fact the way that the Marine Hospital Services that was functioning under the Department of Treasury has been born. Next. Here, I wanted to list probably the 5 most relevant figures in the history of the United States for their involvement and for the relevance of their work and vision to modernize and to change the healthcare in America. Next. There were different periods, and I think it is very relevant to recognize that Theodore Roosevelt was the first to actually call for universal coverage, followed by Franklin Roosevelt, who in fact argued extremely hard for the employer-sponsored healthcare insurance. I think everyone is aware of LBJ's contribution with the Medicare and Medicaid, and also the strenuous effort that Hillary Clinton made in order to promote her healthcare agenda. Ultimately, one of the major steps forward in the American healthcare, according to some, I would say, political visionaries, consists with the Affordable Care Act that was established during the Obama administration. Next, please. This is relevant in the healthcare in the United States. It is under tremendous pressure because we are a country that is seeing high percentage of our GDP in healthcare. Next, please. It is projected by 2027 that approximately 20% of the United States GDP is going to be invested in healthcare. Next, please. What are the major drivers of our debt? Obviously, care for as well as security. Next, please. It is mostly relevant that for 2024, it is appreciated that approximately $860 billion they will going to be spent in Medicare. And also as a prediction, next please. It is extremely relevant for all of us to recognize that although in 2018, it was predicted that we're going to spend $579 billion, we actually what we can conclude is that probably the expenses that we are predicting at this point will be much higher. Next. So what is the impact of COVID-19 on healthcare? Next. It is great, obviously. It was a big challenge. Next. The American Hospital Association predicted that in 2020, the financial losses for the healthcare system was approximately $323 billion. These are data up to January 1st, 2021. The data from January 1st to May are not published and available yet, but this is the figure that was predicted for 2020. Next, please. We have seen that approximately that several practices had almost a 50% decrease in revenue that was secondary to a 60% decrease in their volume. Next. The hospitals, in order to deal with the financial pressure, implement layoffs, furloughs, as well as impose pay cuts on healthcare personnel. Next. At least in March 2020, at the very beginning of the pandemic, at least 43,000, approximately 43 to 45,000 healthcare, they lost their job. Next. And 9% of medical practices had to be closed permanently or temporarily. Next. However, very interesting for all of us, the remote patient engagement increased 225% to the satisfaction of the pioneers in the field that for almost a decade they tried to push for telemedicine, but they have not been successful. Yet the pandemic showed that we can actually do it. And please see at what level. Next. Once again, the same question. What was the impact of COVID-19 on healthcare? The actual fallouts of the pandemic was widespread. Primarily, most of the hospitals have been affected, and in particular, the community hospitals have been affected due to the fact that their elective surgeries were completely canceled for almost 6 to 8 months. Next, please. And these are the most impacted specialties that have been impacted by the coronavirus. Very interesting, OBGYN was not listed as one of the most impacted specialties. Next. We have seen also that in order to protect themselves, the Americans had to shelter in place, and therefore they became in certain areas much ill because they were postponing healthcare, and they were postponing going to the doctors, coupled with, as I discussed before, the lack of accessibility to the primary care. Next, please. In addition to this, we have seen that almost 40 million citizens, they lost their job, and this was coupled with a decrease in their coverage and healthcare insurance. Next. And very interesting, with specific relevance for our presentation today, the deaths from COVID-19 were disproportionately high among Black and Latino communities. Next. So very relevant is that these are data in blue published by the CDC. And as you have seen, you see here on the left side, although non-Hispanic whites represents approximately 58% of the American population, the percentage that they have been impacted in relation to the percentage that they represent in the society, the number of non-Hispanic whites being much higher, relatively their impact was lower comparing the Hispanic and non-Hispanic population that are marked with asterisks. The Hispanic population and the Black population, they represent proportionately a lower percentage in the American population, yet their level of and the distribution of COVID-19 deaths, comparing with the percentage that they represent in the American population, was much higher and impacted by this pandemic. Next, please. Next, please. This was, in fact, obvious in the previous, please. Previous. This is, in fact, the same graph was mimicked in the state of Illinois, in our state. Next. But also, in particularly in our city in Chicago communities. Next. So a relevant question is why we experience what we have experienced. Next. There is a lot of debate about social determinants of health, which are obviously defined as conditions in the places where people live, learn, and they work. Where the Hispanic and the African American population experience a wide range of health and that are worse for these two ethnic groups. Next, please. In addition to many discussions about the fact that Black and brown communities have been victims of decades of system racism and discrimination. Next. We obviously know that also these two populations have been routinely marginalized and were living in segregated communities. And with particular relevance for the city of Chicago, we know that the segregation in our city, it is probably one of the most relevant for the entire country. This population, they frequently live in the so-called healthcare and the food deserts areas. Next. The access to testing was also a very big challenge. Next. But also, in particular, the brown and black communities, they are part of the essential workers. And as you can remember, this population was in fact at the first line, and they could not afford the same protective measures comparing with other populations. Next. And in the absence of a job, the unemployment rate increased, and this was particularly, I would say, higher in the Latino population and Black population, with the unemployment levels of approximately 12% and 14% respectively. Next. Situation across the country. This is a paper that demonstrated that this is in fact finding that the healthcare policymakers, they observe in New York City. Next. But very interesting to me was that once hospitalized, the Black patients were less likely than white patients to have critical illness. And this was for the first time when it demonstrated that, in fact, the highest level of mortality for the Black and Hispanic is outside the hospital. It was very, a very interesting and a very relevant and eye-opening paper and analysis for me. Next. Next. University of Illinois College of Medicine has a long tradition. It was founded in 1882. It is one of the largest college of medicine in the country. And also very relevant for all of us and for our discussion today is, in fact, the impact in the community is extremely high. Almost one in every physician had some form of education at UIC. We are considered, based on several statistics, the #1 medical college graduating Hispanic graduates, and also #5 in the nation in graduating African American physicians. Next. The UIC University Hospital was founded almost 100 years later in 1919. It has 485 beds with a relatively high volume of patients. It has a craniofacial center. It has very new outpatient care center. And also it is part of a system of 12 federally qualified health care centers to specifically address healthcare issues in underserved population. Next. So what was our experience at UIC from April 2020 to May 2021? Obviously, the numbers are changing on a daily basis, but approximately 1 week ago, we reached approximately 270,000 COVID tests that were performed. And UIC was the medical center that, in fact, proposed for the first time that COVID and the SARS-CoV-2 can be identified in the saliva. That explains, in fact, that a large number of tests in the saliva were performed at UIC, the high number of saliva tests. Next, please. This is the graph that displays the number of cases that we experienced at UIC. They mimic to some extent all the peaks that we have seen in the this is the data up to April 2021. That was April 30th. Since then, the line in the graph plateaued. We still continue to have approximately 30 patients admitted per day in the hospital, and 5 to 6, approximately 10 patients that are in the ICU, with the latest number that I have seen, 4 patients on ventilators at this time. Next, please. The graph that displays cases in the intensive care unit, the graph of COVID-19 cases, as I have mentioned before, the number of patients that are present in the ICU plateaued since April 2021. Next. This is the UIC COVID-19 mortality cumulative rate, with a gradual increase in the number of patients that experience this unfortunate event. Next, please. And once again, very relevant for our population was to analyze how our data in the pregnant population, they mimic and they in fact compared with the COVID-19 data numbers and progression in the general population outside pregnancy. So with specific focus on the obstetrical services, we performed approximately 2,300 tests to March 2021, which is the most up-to-date data. All this data, as you can imagine, are relatively difficult to track because there are many patients that have been diagnosed outside. These are cases outside hospital or patients that they were diagnosed with COVID-19 at the time of admission. These are data related to patients that have been taken care of at UIC, that they had at least one test that was positive for SARS-CoV-2 during pregnancy. So we performed during our screening period approximately 2,300 tests. We had 167 patients that were tested prevalent with tested positive with the prevalence relatively high to 7.35, probably a little bit higher comparing with some other medical centers in the city of Chicago. Next, please. Obviously, in this graph, I'm trying to say the number of patients that have been the racial distribution in our pregnant population. Again, similar to the national level, the Black and Hispanic population represented the largest proportion of patients impacted by this disease. Next, please. The blood type did not pay in our population any significant relevance. Next, please. Which was consistent with data that were published in the United States. I specifically wanted to focus on this hypothesis because at the very, very beginning, it was hypothesized that patients that they carry a blood type AB are in particularly vulnerable. Obviously, our experience during pandemic, and when I'm saying our, it's the community, scientific community refuted this hypothesis. Next, please. The vast majority of patients were patients that they were in the 3rd trimester. Next, please. And so the obstetrical emergency room at UIC was the site where most of the patients were diagnosed with test at the time of their admission. Our platform to diagnose COVID-19 was point of care, the Abbott platform for most of our patients. Next, please. In terms of the symptoms, the vast majority and the higher proportion of patients, they had no symptoms at the time of admission, and also they delivered vaginally. Next, please. Next, please. In order to be able to demonstrate and to identify the hotspots for our population, we provide data analysis of the zip codes reported by the patients at the time of admission, and with particular focus on patients that were positive, patients that were negative. So what this graph in fact show in red, represent patients that were positive, where they were located. The lighter green are the patients that were diagnosed, that were tested from April to June 2020. And then in darker green, the new patients that were tested for SARS-CoV-2 from July 2020 to March 21. So the dark green represents the most recent data. However, what we have seen that the vast majority of the patients that they have been taking care, we provided care at UIC, are located in white areas. And what the white areas represents, they are highly impoverished neighborhoods, as determined by the socioeconomic index. It is very relevant, and it was very awakening for us regarding the needs that our population has at UIC. Next, please. Next, I would like to share with you some of the data related to hypertensive disorders during COVID-19. There was a lot of debate about the system that is particularly affected primarily by the viral infection. It seems that a lot of times we have seen patients, we have seen in non-pregnant population that the virus is impacting on the liver function and on the kidney function. This is extremely relevant for the pregnant population because disease and the condition that impacts on the liver function as well as on the kidney function mimics a condition which is called hypertension, which is preeclampsia in our specialty. So what we have done an analysis of several group of patients, as you have seen, patients that they were diagnosed with COVID-19 and they had obviously there were symptoms that they made the physician aware, and they wanted to rule out preeclampsia. There were patients with COVID-19 where the symptomatology was not, in fact, mimicking preeclampsia, and the preeclampsia workup was not performed. But also patients that they were COVID negative, but a preeclampsia workup was ordered for a variety of conditions, including hypertension or headaches, neurological symptoms, or some other symptoms. Next, please. What we have seen that the vast majority of patients that they had hypertensive disorders in the COVID positive group, but also in the other groups were diagnosed with conditions that they require a preeclampsia workup at term in the third trimester. And also a lot of patients that where the physicians, they felt that they need to do a preeclampsia workup. And here, please focus on the first column, was the group of patients that they had chronic hypertension and they were diagnosed with COVID-19. relevance and the increase of the blood pressure at that time, they made the physicians be more aware of the possibility that this could be COVID-19, but it could also be preeclampsia. Next, please. The final diagnosis and the adjudicated diagnosis, which I think is the most relevant for this particular analysis, it showed, in fact, that women that they had COVID-19 and they require a preeclampsia workup, comparing with the COVID-19 that are negative women that they also require a preeclampsia workup, there was no significant difference in this particular group, suggesting that, in fact, preeclampsia was not more oftenly diagnosed in the group of patients with COVID-19. Very interestingly also was that in the adjudicated diagnosis, the gestational hypertension diagnosis was diagnosed, and this was a significant, statistically significant data. Most of these patients with COVID-19, there were, in fact, a lower proportion of these patients were considered to have gestational hypertension, comparing with the COVID-19 women that also had, preeclampsia workup. Next, please. In order to be able to analyze and to determine if indeed COVID-19 is a preeclampsia marker, we build up on a laboratory score that was aimed to grade the severity with which proteinuria is present, the serum creatinine, platelets, liver function test, and all the laboratory tests that we are routinely used to rule out preeclampsia. We have not seen any difference. We have not seen that patients with COVID-19 have a disproportionate increase in their serum creatinine level or in the number of platelets that were that had platelet count less than 100,000. So from our perspective and in our population, the laboratory score or a specific variable part of the laboratory score could not discriminate on its own or as a group COVID-19 versus typical preeclampsia. Next, please. Similarly to the laboratory score, we build up on the clinical score because we are particularly interested in knowing if patients with COVID-19, they had a higher and disproportionate increase in their blood pressure values, in the number of neurological, in the presence of neurological symptoms, as well as in the severity of their neurological symptoms, as well as, once again, all the symptoms that we are routinely used to rule out preeclampsia. Next, please. No difference have been seen. So what we have actually concluded, we concluded that for pregnant patients and that had newly identified hypertension, definitely there is concern due to the overlapping symptomatology with gestational hypertension and preeclampsia. However, the two conditions could not be differentiated based on clinical grounds alone, which suggests that with our search for a biomarker that could differentiate between COVID-19 and other hypertensive disorder, that biomarker it's very much needed. So I want to thank you very much for your time, and I will stop over here, and I'm looking forward to our discussions part of the panel. Thank you.
Thank you very much, Dr. Bahimshi. I'm going to hand this next section over to Rachel, who will read some questions to the professor.
All right, thank you. We have one question here. Jana asks, you mentioned that the research has shown that Black and Hispanic individuals had a higher death rate outside of the hospital. Can you talk about possible factors such as access to care that may contribute to this?
I think this is was very interesting, and probably access to care is one of the major reasons that is responsible for this. Once African American and Hispanic patients are admitted in the hospital, their level of mortality, as I discussed, I mentioned, to be similar to the other ethnicities. So yes, I think access to care remains a major challenge. But there are also, data that I have seen in the literature that try to link the severity of the condition with various genetic predisposing risk factors, which I did not present it right now. But there is a possibility that in the absence of care, the genetics also to play an important role, and in the absence of imposing supportive measures. Yes.
Okay. This question is from Dr. David. The asymptomatic rate in birthing mothers seemed high. How did it compare to non-pregnant patients in your system?
I did not have the chance to analyze the data in non-pregnant versus pregnant population because our healthcare system did not focus and reported the prevalence of the disease and the link with their symptoms. So I was able to comment, I'm able to comment only on pregnant population at this point.
Well, if there are no more questions, we will move on to our next section. Dr. David?
Very good. Next slide, please. Well, again, thank you, Dr. Bahimshi, for that really extraordinary talk and the work that the Department of Obstetrics and Gynecology have been doing at UIC and in the community. So this really is a nice segue to our next section. And I would like to introduce our three expert panelists who will provide some additional insight into the implications of the research presented. So today we are joined by Dr. Melissa Simon, who is Vice Chair of Research for the Department of Obstetrics and Gynecology, and George Gardner, Professor of Clinical Gynecology, Professor of Obstetrics and Gynecology, and Preventive Medicine and Medical Social Sciences. She's also the founder director of the Center for Health Equity Transformation and the founder and director of the Chicago Cancer Health Equity Collaborative at Northwestern University. And she is based at the Feinberg School of Medicine, as well as the Robert Lurie Comprehensive Cancer Center. Welcome, Dr. Simon. I'd also like to welcome Dr. Annie Duty, who is a physician and assistant professor of OBGYN at the University of Chicago Pritzker School of Medicine, and Dr. Beth Plunkett, who is Vice Chair of Reproductive Biology Research in the Department of Obstetrics and Gynecology in the Outcomes Research Network, Program Director for Reproductive Health, and she's a clinical professor with the University of Chicago Pritzker School of Medicine, and she's based at the NorthShore University HealthSystem. So welcome all for a very expert and eminent panel to join Dr. Bahimshi in the next segment, the Incubator Hub expert panel. So if we could move on to the next slide. Very good. So we just watched a presentation that is very sobering in terms of the inequities and the impact of COVID-19 on the Chicagoland population across the world. And this really raises a lot of questions about our public health system. And I'd like to address the panel. Welcome again. And there are 4 questions I'd like to pose. And the first of those is, what are the implications of this research for health equity? And so please, panelists, feel free to go ahead and start, any of you, on this implications question.
Well, I can't start my video, but I can answer. This is Melissa.
Hi, Melissa.
Hi. Oh, here, now they're letting me start my video. You guys had me restricted. In any event, I want to emphasize that it is more than access that is That's the problem with the outcomes that you're seeing with COVID with respect to either pregnant and birthing persons or anyone in COVID. We know that it's not race that's the risk factor, it's racism, and all of the structural, political, economic factors, people call them the social determinants of health, really impact the phenotypes of what you're seeing with respect to the data. So we see the very large Black, Latinx, Native American pregnant and birthing persons having higher rates of COVID across the country, worse outcomes as well. And this is not just because of access. There are many facets of access, but it's also a part of really policies and things that have restricted communities from having access to healthcare centers down the street, that have restricted certain communities of color from trusting the medical care that they're getting, that have restricted communities from having access to fresh foods and physical activity spaces, and therefore may be more obese because of those policies and access or relative inaccess. So I want to be very clear on why we see these disparities, and it's far more than just access.
Yeah, I see this is, oh, sorry, go ahead.
Oh, just very well said, and thank you. That this complex web of social determinants and realities that contributing to this disparity. So Dr. Duty, please go ahead.
Yeah, so I'm a maternal fetal medicine specialist, and I took care of a lot of patients over the last 14 months with COVID-19. And I think, kind of going along with what Dr. Simon says, there are three things that really stood out to me in caring for these patients, where I think the downstream determinants of health really made a difference even in how they fared clinically. The first is the populations that we take care of have much higher rates of comorbidities, especially diabetes and asthma, and obesity as well. And so those complicate the care even once someone is diagnosed with COVID-19 in the hospital, both just in terms of their actual clinical care, in terms of which patients are candidates for ECMO, which patients can be ventilated, also what procedures we're able to perform on them surgically without them desaturating. So it has some very practical implications. In terms of not all access is equal, I would agree with Dr. Simon. I think one thing that we found is that a lot of our patients that get transferred to us for obstetric reasons initially present to other hospitals in the South and West sides, including places like St. Anthony's and Ingalls Hospital. And during the spring, when we had our kind of crush of patients last year, we actually weren't able to accept transfers just for COVID. And so we were able to accept transfers for obstetric reasons, but if we had a pregnant patient who was pregnant that we wouldn't otherwise accept for obstetric reasons as a transfer, we couldn't transfer them just for COVID. And so their physicians would call us to try to get them a higher level of care. And we were somewhat stymied in our ability to do that because the ICU is so full. And so when I think we say access to healthcare, we don't literally just mean, can you walk into any hospital, but are you able to access the highest level of care? And then finally, I think that the distrust in the medical system does play a role. In particular, I've seen that with vaccination with my patients, that some of them are just somewhat hesitant to get the vaccine, and I think for good reason. And it takes a long time and a lot of patients to overcome that trust, and I'm not necessarily always the person who's going to be able to convince them. And so trying to engage community organizations and community leaders, I think is very important in that effort.
Thank you. Absolutely. Dr. Plunkett.
I totally agree with the comments that have been made, and just want to give two bits of thanks before I start. First off, thank you for including me on the panel. It's really a privilege to be here, and thank you for the wonderful talk that was given. It was excellent as always. I always enjoy being in the audience when Catalin is speaking. I totally agree with both Annie and Melissa, and I want to just emphasize that the issue is so multi-layered and nuanced and continues to have really important reverberations across our healthcare system. There's an old quotation that I often misquote, which is every system is ideally created to achieve the results it achieves. And I would say the system in which we practice healthcare, the world in which we live, which is riddled with systemic racism and discrimination, creates a system which achieves the results we achieved during the COVID pandemic. I also want to make one comment just about that JAMA Network article. It calls up two kind of analytical questions. One is, the conclusion was, if you control for determinants of health, and if you control for underlying morbidities, there really are no racial or ethnic differences in mortality outcomes. And I would say, well, just from a modeling perspective, you are probably over controlling, you are overfitting that model. And then from an analytic perspective, I would just question whether you can really even separate out underlying comorbidities and social determinants of health. For me, they're along the same causal pathway, that you have social determinants of health that then result in underlying comorbidities and then result in death from disease. And technically, you can't really parse out individual contributors along the same causal pathway. You can think of them as mediators or contributors to an outcome, but you really can't control for them other than to understand that they are contributing to your outcomes.
And then you've got to add a little more. So think about how rapidly our hospital policies were changing, sometimes week by week. Sometimes, we were literally building the rocket ship while we've been flying it this whole year. I mean, now it's a little more stable with respect to our hospital visitation policies. But if you already are a person of color and you're pregnant and you're about to give birth, which is supposed to be one of the most special times of your life, right? And you can't bring a partner with you if you're COVID positive, right? Or you can only see them by phone or by iPad, smart, whatever, tablet. Or you can bring one person with you, but you already have a fundamental distrust of the healthcare system. You already have, you don't feel that you're going to be heard. Your voice may not be there at the table when you're trying to make decisions during labor or trying to listen and understand the decisions. So you might want a doula with you or another support person. So these policies were changing moment to moment and were very restrictive if you had COVID or no COVID in the very beginning of the pandemic. So that added an extra layer of access, an extra layer of complexity to this whole thing as well. And we have to remember that context. In some parts of the country, women were trying to choose home birth if possible. So, I mean, there were a lot of complexities to this on top of complexities.
Yeah, very well said. And I guess it's been a year now since this pandemic, actually more than a year, hit Chicago. And moving on to the next discussion question, are there glimmers of hope that through efforts that have been very strategic, deliberate, and at least recognizing health inequities more formally and more broadly, that our health systems are starting to respond to these upstream causes of the health disparities? And I think certainly around vaccine trials, there's a big effort at UIC to recruit people of color. I think they're very successful. I think there are efforts in West Side, South Side, Northwest Side from our institutions, but I would really love if you could all comment on areas of progress, green leafs that might be leading a little bit more towards trying to use this as a lever to begin to close health equity gaps using dissemination implementation.
So I could comment on one thing, which maybe isn't exactly the answer you're expecting. But one of the positives I think that has come out of COVID, it's actually been the use of telemedicine. So particularly to address some disparities that we may not always think of, including a big one in obstetric care, which is the difference between care for women who live in rural areas versus urban areas where there isn't perhaps a maternal fetal medicine specialist for 200 miles. I would say in general, I see two types of patients, one of which is the ongoing prenatal care. I see them often in the office. I see them, every couple of weeks. And we did do some of that via telemedicine. I think in general, that care goes better if it's in person, at least some of the time. However, we have successfully used telemedicine for two areas that I think are really going to help expand access to care in the long run. One of which is for patients that just need to see me for a one-time consult, in which I'm mostly just talking to them. It has been very helpful to be able to do consults over telemedicine, so patients don't have to drive 2 hours, pay to park, come see me for an hour while I talk to them, and then drive 2 hours home again. And so I think in the long run, if we can keep that for telemedicine, that would be really helpful in helping reduce disparities, especially if we can find ways to coordinate care with local obstetricians for ongoing consults. The second area is we, as soon as COVID hit, we started, I think my division director went and bought 500 blood pressure cuffs herself. And we started giving them out to patients and teaching them how to check their own blood pressures. And this has actually turned out to be really, really, really successful, and that most women have figured out just fine how to take their blood pressure. And we've used telemedicine to call them and check on values. But I think it's made them much more aware of what we're looking for, what the danger signs of preeclampsia and other hypertensive disorders of pregnancy are, and they become invested in their own health and taking their own blood pressures. And so, as opposed to what we feared at the beginning of the pandemic, which is that women would be sitting at home with preeclampsia, we've actually found the opposite, that women have become much more involved in identifying their own dangerous blood pressures and presenting for care. And so I think that is one positive thing we can take away from this.
I'm going to share with you. I'm sorry, I'm interrupting someone.
No, Dr. Bahinshi, I was actually going to ask you to reflect on what Dr. Duty said because of the work that your organization is doing in this area.
Yeah, the same experience, and as Annie described, I'm just going to be very curious to know from everyone that works in other healthcare systems, what is their experience with let's say the interaction that we have with the patient. And I can tell you that we have been, at least at UIC, very straightforward, and we in particular we have part of the OB scorecard. We are building a racial disparity scorecard, and we have seen very clearly that this profile is not only let's say only for COVID-19. We have seen rates of preeclampsia higher in this population. We have seen higher rates of preterm birth in this population, admission to the NICU, and so on and so on. But I just want to share with you that from the very, very beginning, and especially when the vaccination was open, we went and we discussed with the patient specifically to African American and Hispanics to emphasize, to say, we pay attention to you. We want you to be healthy. We want you to understand that we in particular recommend to you to get the vaccination because you are at the highest risk. And recently it's getting a little bit better in our population, but at the very, very beginning, there was a huge mistrust. And I was always, conflicted. I just simply didn't know why, because they have access to data. They are reading about and they're profoundly by this. But very rarely we could identify in the high-risk population patients that they said immediately, yes, I understand that I'm at the highest risk. Yes, I want to be vaccinated. Most of our patients were, I'm going to get vaccinated after I'm going to deliver, or I'm going to think about. And this is the same population, because we asked, we are very curious, but did you get your flu vaccine? we got exactly the same answer. So it's once again, the mistrust. It's not only at the level of COVID-19, it's also related to other conditions. So I'm just very curious. Lately, I think it's getting a little bit better, and I think it's getting a little bit better in the low-risk population, but this is our experience at UIC, and we struggle with that. We struggle quite a lot with that.
Right. And I think the other thing that I've just observed is that many health systems are at least acknowledging that there are social determinants of health and making some effort to begin to address them, food security issues, a range of different things, and document. So in terms of implementation, it's a measurement is one issue, but then how to do what we know works already across the board is something where I'm curious to know what your health systems are doing beyond telehealth, beyond recognizing the problem, but systems. And maybe it's where we need to go next. And, beyond understanding the different layers of the onion that contribute to these problems. But any thoughts on health system solutions? Dr. Plunkett?
I don't know if I can speak so much for NorthShore other than I would say that I've observed NorthShore has had very much a health system, meaning our health system, sort of an introspective view of the world. Like NorthShore has, I think, done an excellent job of promoting vaccines and disseminating information for patients who belong to NorthShore. But that is very different than I think the question at hand, which is from a public policy perspective or from an implementation of healthcare to the most highest risk communities, what should we be doing? And Sean, we're both from NorthShore. I don't know if you've observed the same thing. There's been not the same public health focus that I perhaps would have hoped for. And so I would say one thing that a health system could do would be to have a public health focus. NorthShore did a great job partnering with nursing homes and making sure that those patients who were in facilities got vaccinated as a top priority. But other than that, partnering with community, I have not seen a lot of NorthShore really reaching out into the public health arena. There's almost been a division of that's the departments of public health responsibility, not ours. And so I would say that's one thing that could change. Healthcare systems could utilize their organizational leadership and skills to help reach out into communities to find solutions to these really pressing problems.
Well, you raise an issue about the separation between healthcare and public health, in general. And I think that there's a lot of community engagement work that NorthShore has done, that UIC's done, that Northwestern's done, University of Chicago's done, but kind of squaring off the triangle with its dissemination of healthcare services in a public health, population health way is something that is, I think we're all trying to figure out how to do that. And
I think what it comes down to, when it comes down to this is that we each have to recognize at our own positions and at our own institutions where we sit in the gatekeeper realm. This is all, equity and health justice is all about looking at where are the gatekeepers, where are the areas where the gatekeepers have the opportunity to set things straight, right? To actually change policies and practices that actually become better for everyone as opposed to just favoring some and oppressing others. And so every single person and institution or unit has a role to play once they figure out what their gatekeeping responsibilities and privileges are. And once you realize that, then you figure out how much impact you actually can have when you start to bend the needle a little bit and reshaping policies, rethinking how things are done. So one thing that was really clear on the vaccination front is it's not just about distrust that we have earned. We earned that in the medical and science realms. We've earned that distrust. It's about not calling it that and saying, well, that's the reason why X patient is not getting the vaccine, because that puts the blame on the patient. But if we actually empower the patient to seek the information or to access the information that he or she or they need to get to that yes, and to create the solutions to getting access to the vaccine from the communities themselves, because the communities actually know, this is where the community engaged approach comes in, the communities actually know what worked better for vaccination distribution. We saw that happen on the ground. You know, I've been a part of the mayor's team and the governor's team. We saw that happen on the ground in real time. For example, when we had the National Guard at mass vaccination sites in their uniforms, we knew certain populations, example Latinx, who do not trust the military uniform whatsoever, were not going to access those vaccine sites. We knew that that ZocDoc platform was not going to be the platform for certain generations or certain communities to access appointments for vaccine scheduling in real time. So we have to think about these gatekeeping things. Same thing at the level of NIH and pharmaceutical companies. It is obscene that pregnant persons were not allowed and lactating persons were not allowed to be in trials up front for COVID vaccine. It's obscene. It's egregious. It's actually discriminatory. So, you know, who decides these questions? Who are the gatekeepers? That's the important thing to think about when you're talking about health system shift and real change that aims towards justice, not just equity as we'll just check the box, but actually starts to view things and change through that lens.
Yeah, and this really also segues to the next discussion question, which is what are the implications of this research for policy? And I do think this issue of the gatekeeper roles and really identifying those that are the relevant ones for some of these injustices and working with communities where there's trust, where there's realism and credibility. We have several comments. One of them is just to mention that NorthShore has been partnering with the Evanston Health Department to do vaccination clinics in faith communities, specifically to reach communities of color. And as well, Rachel asked the question, are physicians ever informed to handle disenfranchised communities from the perspective of the trauma inflicted upon them from the actual healthcare community over the decades? So this gets to Dr. Simon's point. It's a great question. Would any of you like to comment on that? I mean, I can. The answer is probably no, unless we've done masters in public health with the social determinants, you know, I mean, no, I don't think so. And this is a real opportunity to change curricula and from the whole pipeline from pre-doctoral to medical school, residency, and CME, because we really aren't informed on how to handle disenfranchised communities from the perspective of people dealing with people who've experienced trauma, but also the broader issue of having the humility to ask people, you're the experts, tell us, we want to partner with you and get you on the ground level and finding the solutions that work and meet you where you are. And so, but if others could comment on that too. Certainly know that with the ITM that there's, on the research side of things, there's a lot of community consultation. But ideally what we would like is have this to be linked with clinical, with primary care, with the delivery of innovation and design of how the system should work. But
I would say that in the last 5 years, maybe ever since the Me Too movement really got going, I feel like in obstetrics and gynecology, there is a push to think about trauma-informed care and all of the consent involved with doing pelvic exams and other obstetric procedures and obstetric violence on an individual level. There's much more of a focus on trauma-based care in both the sort of the professional literature of ACOG and the Green Journal and other journals in the field, as well as research. And so it would be great if we could use COVID as an opportunity to really start talking about some of these conversations. To Dr. David's point, I'm not sure that we're there yet. That's a really good question.
So are there policies, state, local, federal, that we need to enable this transformation in education? Or do we just need to do it?
I think in some ways I'm not the right person to answer that question. I think one thing that's been really, really helpful in terms of learning about trauma-informed care on an individual basis is hearing both from the patient's perspective as well as from research. I think what's been very helpful is implementing universal policies, such as having to have chaperones for all exam, regardless of the gender of patient and regardless of the gender of physician, because it shouldn't be up to the patients to decide what they need. I think one way to approach this that is not going to be helpful is just to make it another, LMS module that somebody ticks on the box and says, okay, I've done this training now in a completely non-interactive way. And so I don't know what the answer should be, but I think it needs to be more thoughtful than just another module that we all complete every year.
So thank you very much. And do we need more federal dollars to support education, or really just how to redesign the way that we connect with communities? Is it a matter of money, or is this a matter of decisions and maybe engaging more with members, local champions, members of communities, so that they're part of the planning process so we could prepare for the next pandemic?
I think humility is important, and realizing that you're maybe not the best person to answer this question. I think trust is not something that's built overnight. And so I think, like someone said previously, engaging all levels of the health system and working with communities to build trust ahead of time before the pandemic hits is really important. And then I think engaging, obviously, medical schools and medical education at all levels is important also. I don't think this is really a matter of money. I think it's a matter of people actually caring about it and working towards figuring out what works to change attitudes and behaviors. And also, I think that if you change rules over time, you will change culture, in the sense that when I was an intern as an OBGYN resident, it was not the culture that we had a chaperone for every pelvic exam. And in fact, we would get in trouble if we didn't get our exams done fast enough sometimes. And that, did not involve waiting for a chaperone. I think now that the culture is that we have chaperones for all exams, people find it actually very interesting if you try to do an exam without a chaperone. And I think the way that we teach medical students how to do public exams has completely changed due to culture changes also. And so I think it's more than just money, and it's more than just checking a box, like someone said.
I think Rachel's points of, how do we really think about the trauma that the medical system has inflicted upon communities is really parallel to Annie's comments on, individual trauma-informed care, and then Melissa's point that, like, we own that trauma. And I have to say that was not part of my medical education, and I don't believe is part of the current medical education. And I think that's something we should think about, and we should really think about that from a historical perspective and the implications today, because I really do think we have created where we're at. And until we acknowledge and recognize that, we're probably not going to come up with much by way of sustainable solutions.
Right. And this issue of trauma comes up ubiquitously when dealing with issues around implementation in precision medicine, for example. including historical traumas. And there are so many notable ones that we need to do more than just have lectures on eugenics and things like that. We need to actually, build this into our education. How do we be mindful of this? I think, but this is we have to get past this issue without putting it in the back burner because it's still very much real for people in so many ways. Are there future translations?
Sean, I'm just gonna make a short comment, and I would say that very rarely in my career and in my experience, I found a situation where money didn't help, especially in healthcare. So I think it's a little bit of a combination of both. And when we refer to all this policy making and changes and everything, it's not only about COVID. Let's just think a little bit about the Chicago Department of Health program to address the issue of hypertension in postpartum period and the needs that healthcare systems in general, they need, the resources that the healthcare system, they need to penetrate in the community. The issue is that this story does not stop in the hospital. This story continues outside of the hospital. And in order to have healthcare workers penetrate within the community, going in the patient's environment, being with them and understanding what's going on and providing the support where they are, it is a very expensive, proposition. How you do the business of medicine and how you challenge, the healthcare systems versus the federal systems is a completely different. I think to me, a combination of both, getting trust, having people trust in your good intention. There is still an issue that is, as a white non-Hispanic, I am thinking of it on a daily basis, and that's the issue related to the outcomes of the African-American population and the neonates, which in some publication is advertised as being better when child or an infant or a newborn of an African-American patient is better when it's taking care of an African-American physician. And I struggle with that because I know how I would like to believe in an idealistic fashion that we have only one mind, and that's that of a physician that is applying its medical knowledge and skills in an unbiased fashion. But probably there is, so in order to understand all of this, we need to combine the human resources, the creativity, penetration into the community, but all of this sometimes could be very expensive. And we should not give up when we don't have the money, but we should also try to the best of our ability to provide the resources necessary to accomplish our goals.
Thank you very much. We have another comment, and the next discussion point has to do with the implications for future translational research directions. But the comment is from Dr. Stolberg: do you think doulas and other patient advocates at the site's moments of care can make a sizable difference? If so, how do we structure care to welcome and empower these advocates? I really appreciate Dr. Duty's point that time, the pressure, or rush on providers is one of the structures that disempowers patients and advocates.
Yeah, absolutely. I think thinking outside of the box is required. Not that doula care is outside of the box, but I think we are so rigid in the physician MD model of practice or model of care, especially whether it's prenatal care. It's very checklist oriented and routinized, right? The majority of patients in this country, pregnant persons in this country, receive perinatal care that's very routinized. You get your first prenatal care visit whenever, and that you address the whole kitchen sink or refrigerator full of items in that visit. You pack it into one, and then you space out the visits in a cadence that's pretty templated, depending on what your needs are. Like if you have diabetes or hypertension, then maybe it's more frequent. But if you have no other comorbid conditions, it's, you know, 4 weeks, 4 weeks, then 3 weeks, 3 weeks, then 2 weeks. I see my residents like scared to tell me the wrong answer with respect to the follow-up. And that's BS. We have to stop that templated, very rigid way of thinking about how to deliver care, especially in prenatal care or perinatal care. Why can't there be 2 first prenatal care visits? Why can't there be 2 in the first maybe 2 weeks apart to space out some of this stuff? Why not a trust building visit whereby I'm not going to have you get undressed. I'm just going to talk to you about what are your hopes and dreams about this pregnancy? What are your fears? All this stuff that we forget to do, or that maybe the social worker or the nurse may do in passing, or the medical assist. But we need to think differently about care delivery and include some telehealth visits in the part, right? Include doulas. So doulas are often in the parallel world, and they may hang out with your patients and you don't know it until you get to the labor floor. Well, who set it up that way, right? You know, things like that. If we're going to think about implementation and strategies to improve healthcare delivery that are equity focused, it really requires some hard thinking on what we're really doing with respect to care. What do we really want to be the outcomes, right? And center the woman herself in that care provision, as opposed to, well, this is what the ACOG Hollister form requires me to do, right? If we think that way, you know, same with postpartum. We are the only state, we're the first state in the union to have this 1 year public aid postpartum care allowance, right? So why aren't we thinking outside of the box with respect to how that happens? How do we operationalize that 1 year, right? Is there a 1 week safety checkup, right? Check in where I do a telemedicine visit 1 week out, just to make sure you're all right, right? No matter who you are. So things like that, I think we really do have to go there with respect to pushing the boundaries in translational research and in healthcare delivery, healthcare services research and perinatal care.
I like
Amen.
Dr. Simon's points
Well
about
said.
doulas coming only in the inpatient setting. I think when they only come in the inpatient setting, people tend to see them as more like the enemy or obstructionate. Whereas in reality, if we knew them all along and they came to clinic all along, we would probably have a much better relationship with them by the time someone actually goes into labor. And I think they have done studies that shows that doulas can be very helpful, not just for obstetric care, but also for things like abortion care. I think unfortunately, who gets to have a doula in this country is really non-random. And some of the best ones I've worked with are ones that are funded by a nonprofit here on the south side of Chicago that partners doulas with teenage mothers who otherwise might have to labor alone. And they are wonderful. And I think exploring that as a model of care to improve outcomes would be really helpful.
So on that comment, fantastic panel. We are at the end of our time. I would like to take a moment and thank everyone, but also to talk about the next steps in terms of the evaluations and the posting of the video. I would really, I'm so grateful for all of you. You're so busy and you're walking the talk and you're seeing patients and you're managing these issues through a very turbulent year. But the depth and the richness and the openness of this discussion was fantastic. Thank you, Dr. Bahimshi, for a really quite an amazing journey through the history of the precedents of this crisis and about what you're seeing in Chicago in birthing mothers with COVID. And all of you very much. This has been fantastic. And we'd like to just move on to the next slide, please. So yes, so if there are any questions, comments, concerns, or requests to present at a future seminar, please contact me. My email is right there. There's an evaluation and we will put that in the comments, link to the evaluation. If you can go ahead and go to that link now, that would be fantastic. We'll leave the Zoom on long enough to use the link, but also we'll send out an email afterwards with a link to the evaluations. We really do read them, and they're really helpful to us in trying to address how to make this the best possible learning and networking experience that we can do. And then finally, a recording of the seminar will be distributed to all attendees. And this should be done either this evening or by tomorrow morning. It'll be on YouTube. So for any of your learners who missed it or your colleagues, please feel free to share it, and it will be kept up there for the future. The next seminar will be in September. And we're going to be having a different seminar series, which is a CME event, Precision Health Equity in Primary Care. And that will be on Thursdays, and that will be announced more widely shortly. But I'd like to just again thank everybody for this really outstanding seminar. So round of applause with the little hands. But thank you all so much.
Thanks for having us.
Thank you for inviting me. It was great.
Thank you. Thank you very much.
Thank you, Cataline, Beth, Annie, Melissa. Good
Thanks.
to see you. Okay. Bye-bye.
Happy birthday.
Happy birthday. That's right.
Happy birthday, Melissa.
Thank
It's
you all.
good to see you, but I'm in the dark, but it's just because I'm in Europe. That's it. But it's good to see you, all of you.
Okay, thank